Hello, good morning, good afternoon, and very good evening, everybody. My name is Saima Asghar. I'm a social worker and one of the directors, ISSUP Pakistan chapter and executive director, New Life Rehab Center, Sialkot. And today I'm going to serve you as moderator with one of our honorable colleagues from ISSUP Global. And on behalf of ISSUP Pakistan chapter, I would like to welcome you all to join this webinar on a very important topic, Gamma Hydroxybutyrate, as the new storm for mental health and addiction professionals inside from developing countries. And I'm honored to share that we as National Chapter ISSUP Pakistan hosting this webinar with the support of our parental organization ISSUP. So I would like to share a brief introduction about ISSUP quickly. ISSUP stands for International Society of Substance Use Professionals, which is an international membership organization with over 30,000 members from all across the world, including Latin America, Africa, Europe, Asia, and Middle East. And there are around 30 national chapters also has been established under the umbrella of ISSUP Global, and ISSUP Pakistan chapter is one of those. The main objective for ISSUP is to connect professionals through networking, knowledge exchange, and training, sharing the very best in evidence-based ethical approaches and promoting quality in all areas of substance use prevention, treatment, and recovery care practice. And to know more about ISSUP, I would like to refer you to visit ISSUP website, which is www.issup.net, where you will find the information how to sign up for free membership if you are not the member of ISSUP yet. The website also has a wealth of resources and publications for you to learn and enjoy. Before introducing one of our colleagues from ISSUP Global team and our speaker guest, I would like to share a few guidelines for all of you. As usual, you all have been muted to avoid background noises, which may distract you from learning to the webinar. But if you want to share any feedback or you want to ask any question regarding the topic, please use the chat box and we will try all our best to answer your queries after the presentation and during the Q&A session. Now I'm very excited to introduce one of our very experienced and committed personality with us, Mr. Jeff Lee. Mr. Jeff Lee is going to support this webinar us today. Mr. Jeff Lee was ISSUP's first executive director, overseeing its establishment. He's previously worked as executive director, Mentor International, abuse prevention for international non-government organization. Mr. Jeff Lee has asserted the role of education and to need to promote personal and social skills and competencies within a health behavior context as a key element for tackling substance use prevention. Mr. Jeff has worked in more than 80 countries, which is including consultancy work for governments, WHO, and UNODC. Mr. Jeff has written and contributed a number of publications in the field of health and drug addiction. And currently, as a senior consultant for ISSUP, his focus is to support the establishment, development, and support for its national chapters. So I would like to welcome Mr. Jeff and thank you to be with us to support this webinar. You are also requested to please continue this webinar.
Saima, thank you very much. That was very kind to say those things about me and my background. When the star of the show, Dr. Usama, is the person that really needs to be highlighted. But I would like to thank you, Saima, for making this possible and the work you've done with ISSUP Pakistan. And I'd just like to say to those of you who have joined, and I know there's a lot of interest in the number of people that have registered for this event, to say that it's a pleasure always to be within an ISSUP webinar, that we've had so many over the last 2 years. And they've provided that opportunity and forum for people to learn, to share, to challenge, to question. Not all that's said will we all agree with. Not all that's offered is something that ISSUP would agree with, but they have provided a forum where people can be challenged, where they can learn, and where they can share together. And there's no difference today. We have the pleasure, and it's my honor to introduce Dr. Usama Bin Zubair to introduce this webinar on GHB. I won't try and spell it out and speak it out like Simon, because I'll get it wrong. But it's obviously an interest, and isn't an issue that is a lot of interest in, and a lot of people need to know, would like to know a little bit more information. And I think we're going to learn a significant amount from Dr. Usama this afternoon about GHB. As Simon has said, I think the key is what we do with that information, and we hope that you will offer your questions and come back with the challenges or the issues or the concerns or the additions that you can make to what you hear, because as ever the information, the key question is what do we do with that information now we've been given that expertise and experience that Dr. Usama brings to us in giving this input this afternoon. So as I say, please use the question section of the presentation of the webinar, and then we'll look forward to the question session at the end of Dr. Usama's presentation. So without more ado, I would just say thank you to you, Dr. Usama, for giving your time, your expertise, your experience. I won't go through all the range of qualifications and expertise that you bring. I note some of the things that you've done and you're interested in, which certainly I would love to take and have a further chat with you about and learn about from you. But on this occasion, just to say thank you for joining us and for sharing your views on this issue of GHB, and over to you. Thanks once more.
Thank you so much, Jeff. I am really honored that ISSUP and your organization, you approached me and we decided this topic. There were a number of reasons why I chose this topic. Usually when we talk of addiction professionals, or we talk of addiction psychiatry or field of addiction, we usually talk about cannabis, we talk about opiates, we talk about cocaine, or we talk about benzodiazepines. It's very less information available on GHB, which is Gamma Hydroxybutyrate. And especially when I talk of developing countries, I have worked in developed countries as well. I have worked in UK, I have worked in Ireland, and now I'm working in Pakistan, which is a developing country. And when I came back to my country after a few years, I just observed, I saw there's a complete change in scenario. Previously, this party culture was very less prevalent here. When I came back, and I have been practicing here for last 8 to 9 months, I have seen a complete change. So this party culture, which is increasing day by day in developing countries like Pakistan, that has just given a gateway of so many substances which were never like used previously in my part of the world. So today I'll be just touching GHB, and I would be very interested in questions, or if people could share their experiences in the chat box. We may not be able to discuss all of them, but that would be a good source of information for me. And these are my social media handles, or my email could also be provided if anybody wants to interact with me or wants to provide some information. So these social media handles may be useful. So first of all, I would like to give 2 disclaimers. First, I have written this for on the instructions of ISSUP and my team, that this is just for informational purpose and this is not a treatment advice, because we have a wide range of audiences. Initially, when I was preparing for this presentation, I thought that it would be just addiction professionals. There would be some psychiatrists, some psychologists, some social workers, some addiction professionals. But then I came to know that this is open for all. So then I had to tailor it according to the need. So nobody could start any treatment after listening to this. Second disclaimer is by my own self. I am not a trained addiction psychiatrist. I am a general adult psychiatrist with some special interest in addiction psychiatry. I have worked in Ireland and now I'm working here as well. And plus, I am trained in some emotion-focused therapies like DBT, which is directly or indirectly related with a lot of people having different substance use. So with these disclaimers, we'll start. So why I have put this slide first? Because the substance which we are discussing today, GHB, I'm sorry I pronounce H in an Irish accent, but that really reflects my training there. So what is GHB? It is a party drug. What is the difference between a rave and a party? You could find number of definitions of rave. So what is a rave? So it's just not the parties occurring in some nightclubs or in some clubs, but now basically this rave culture has extended into big parties, like people hiring their farmhouses and going into suburbs, maybe villages, maybe towns, and arranging big parties. So in my part of the world, which is a developing country, and people think that this may be a poor country or that this may be an underdeveloped country and people would be all the time busy in making both ends meet, but that's not the case. We have a big upper elite class which is doing some parties, and they have farmhouses and they arrange these raves there. And again, this is not then confined to that one particular class. There are a lot of friends and extended families or the invitees which also belong to some lower middle class, which may have to report to some government hospitals which don't have even psychiatrists or addiction people once they use these drugs. So this slide shows rave can be anywhere. In my part of the world, it's usually in the farmhouses in the suburbs of the cities. And I leave this point here, farmhouses and suburbs of the cities, because this would be very important when I'll be discussing the management of GHB toxicity. So now this can be made in homes as well. The main issue is, even today, I was seeing a patient and he told me that he is into some party drugs, and he told me some names which even now were not included in this list of names. Now you can see the party drug GHB. It can be Blue Thunder, it can be Nectar, it can be Remforce, it can be Xyrem, it can be 1,4-B, it can be Tranquil G, it can be Weight Belt Cleaner, it can be, it can be anything. And I have written like a lot of names, and just today the patient told me a name which is not into these names, and I was unable to identify. I googled that, and he told me I used 1/4 of this pill in the party. So I knew when it is a pill, it won't be GHB. But what would that be? It's ecstasy, it's methamphetamine? I had no clue. So the important point is, as addiction professional, or even as a layman living in the society, adequate knowledge of number of the wide range of names these substances sometimes become very important. Because when usually the psychiatrist, they are not the people who are receiving these patients in emergency. It's ED doctors, it may be GPs, it may be ED nurses, and the person who is taking them to the ED, maybe some relative, maybe some friend, maybe some bypasser. So it's very important to have adequate. It may not be very nice to know names of these drugs if you are not a psychiatrist, addiction professional, or maybe a substance user. But I think this is the need of the hour, seeing the magnitude of substance use problem all over the world. So how are they used? This is very important, and sometimes it becomes very dangerous as well. They can be produced in a clear liquid or a white powder or a tablet or a capsule form. So it can be used in bottles and eyedroppers. So you cannot even understand that somebody's in a party, he or she opens his wallet or his purse or his handbag, and there's a bottle of eye drops, and in the party she or he is giving those eye drops to everybody. Even CCTV cameras may have catch that. And when there's some toxicity or somebody has brought the patient to the hospital and you're just told that he had some eye drops, so you can have no clue that eye drops, and the patient is comatose. So this is very important, that there are a lot of things which can be carriers, or which can take form of this substance. So now you can see with the blue dye it can be midnight blue, with the green dye it can be blue nitro, and then there could be number of forms. So, and how many different phases it could be used? Long time ago it was sometimes used as an agent of some anesthesia medication. Then bodybuilders tend to use it for muscle gain. Then a lot of people who use alcohols, or who use some other CNS depressant, when they have a drug test and they cannot use those drugs, they take GHB, because it is not tested. It is not get tested in routine mandatory drug tests, which a lot of firms they carry out. And a lot of elderly people, for sleeping purposes, or for just there as a as a stress coping thing, they use. And then very strange uses, there are few drugs which are called date rape drugs, and unfortunately this is one of the date rape drugs. How it is used in that, we'll discuss in coming slides. So as I told you before as well, any substance, it can be in the water bottles, it can take the form of clear liquids, it could be in the water bottles. What does it do? Now I know that there are a lot of the audience has a variety of people. There would be a lot of people who would not be knowing psychiatry or brain sciences or neurosciences. So it is just to tell you that it works very similar to alcohol, it works very similar to benzodiazepines, it works very similar to barbiturates, and basically it's sensitized in brain as well, but in a very limited quantity. So this mechanism of action tells us that when we use it with other analogs like GLB, with benzodiazepines, with alcohol, so they all would potentiate each other's effect, and that could be a disaster. So what does it do? In lower doses it can have sedative effect, but as the dose increase, that sedation can turn into sleep and coma, respiratory depression. Basically mechanism, if you remember last slide, it would depress your brain, it would reduce activity of your brain in almost all areas. And this is the main effect, that this is a prime drug at raves and also for date rave. Why date raves? Because now here the last line, it causes amnesia, it causes you to forget what is happening with you, it makes you susceptible to suggestion. So you can see it would be ideal for the person who wants to rape. The victim would forget it, the victim, if suggested, would participate in the activity. Later he would become confused, drowsy, euphoric. So this happens if you give somebody, or if you take mild GHB, this would happen. I hope I'm clear now how it is used in as a date rape agent, and what happens in mild toxicity. So severe toxicity. Now again I have to explain what is GCS. GCS is Glasgow Coma Scale. When anybody presents to ED with reduced level of consciousness or confusion, we calculate this score. And if this score is less than 8 or 9, the mortality rate goes very high, the morbidity rate goes very high. So at the time of presentation, calculation of GCS is very important. And we can just see that 66% people, like 2/3 of the people, they present with a range of GCS which makes them very high for the risk of mortality. And then half of these may have at 3. 3 means that patient is almost dead and it is very difficult to revive him and he may need a critical care unit admission. So now here comes, when I told you that these parties, these raves occur in a farmhouse, away from cities. So nearest hospital would not be having a good ED, would not be having a psychiatrist, would not be having a critical care unit. So if a patient is presenting with GHB overload in a peripheral hospital with a GCS of less than 3 or less than 9, it's a disaster. Then it can cause frequent vomiting, which can lead to aspiration. Then all the signs of CNS depression, seizures. So again, episodes of combativeness, episodes of aggression, and then followed by very much depression of respiratory system and CNS. And later, if uncontrolled, if not managed adequately in ED, in a medical unit, in a critical care unit, it can lead to death. And now I have told you repeatedly that if used with benzodiazepines, if used with alcohol, it can be a disaster. And we know that in raves, in parties, alcohol is not considered as a drug. Alcohol is sometimes not considered as a substance of like illicit substance. It's consumed in a lot of cultures in West, even in my part of the world, it is used like as a drink. But in parties, when everybody is drinking too much, causing CNS depression, in addition taking GHB, which is also depressing the brain, so disaster is on the door. So if the person has taken GHB or GHB with alcohol or GLB or any other analog, so we'll decide the treatment according to immediate treatment if you are suspecting toxicity, mild toxicity or severe toxicity. So initially supportive treatment is you have to take him to nearest ED. Now this becomes very important for common people who like it may be sometimes as important as learning CPR, because CPR, if a person is having cardiac arrest, CPR, you would be able to save him at the site. Similarly, if somebody is having GHB toxicity, severe toxicity, which has a very high mortality rate, and you know how to save him, how to take him quickly to the nearest unit and tell them what he has used, that could be life-saving. So call emergency, take him to the nearest good hospital. There the doctors would give him supportive treatment, maintain IV line, see the vital signs. Then positional asphyxia, sometimes it becomes very important. Airway could fail, aspiration, vomit. So, but when you are a doctor, now this slide is maybe for a doctor. If you receive a GHB analog patient in emergency, and now this doctor won't be a psychiatrist. And if a person becomes unconscious or a person is taken to ED who is confused or conscious, a psychiatrist is not immediately called. So it is the ED doctors which need to know this. First, they have to protect themselves. Patient can be combative, patient can be aggressive. He can vomit at any time. And then if he becomes aggressive, suppose this was a episode, he becomes combative, he becomes aggressive. So, and you give a benzodiazepine, what would happen? We have already told. Benzodiazepines, GHB, alcohol, they work in a similar way. If used together, that could be a disaster. So you can give iatrogenic harm to the patient. By iatrogenic harm, I mean you're doing in hospital something trying to do good for him, but that would be disastrous. No benzodiazepines in this patient when he's having GHB overdose. Then involvement of critical care team, this intubation, and if he's having GCS less than 9 or less than 3, he's going towards organ failure, then he may not be managed at ED. And even if he's at a primary care unit, he would be needing a state-of-the-art ambulance to shift him to a tertiary care unit with a critical care facility. Because again, now go to the demography. Sometimes demography of the patient is more important than even clinical data. So the rave culture, the parties, they are usually young people. So you have a young man who has overdosed a substance, who is not having any other comorbid medical and psychiatric condition. He could be saved, but if he could only be saved if you take some timely actions suspecting GHB overdose. So the eyes don't see what the mind doesn't know. So if you don't know about GHB, if you don't know, you know it may be alcohol, he was at a party, it may be alcohol, it may be ecstasy, it may be cocaine. The patient is slightly aggressive, irritable, okay, give him a benzo. So now you should be well aware that benzo would not be a good choice. GHB could be there. Immediate transfer to a tertiary care facility is need of the hour. And it's very difficult to assess overdose because this is very short acting. Patient would be having amnesia, we have already discussed. So even if the patient is semi-comatose, confused, Even if he's alert, he may get amnesic. He may not even tell you he was at a party. Then sometimes prosexual appearing behavior. So you may confuse it with alcohol. You may confuse it with some psychiatric condition. You may consider he may be manic at the moment if he's aggressive, combative, prosexual behavior. You may think this is a manic episode. Okay, give a benzo, give her some antipsychotic. So it becomes very difficult to assess GHB overdose in a person when you have no collateral data at ED. This is again basically for the ED doctors or the people who are accompanying the patient to the ED. So what does this mean to me? Why I chose this topic? Because I have seen in last 8 months in my country that this rave culture is increasing, this party culture is increasing, this GHB use is increasing, and then I would be very uncomfortable when I am unable to treat the train the ED doctors. So that's why I chose this platform, that people should know that clinical course is very unpredictable. Very quickly there's change in mental state, there's change in respiratory state, and you can lose the patient. And again, I told you it could be missed as some ethanol abuse as they are co-imbibed. So patient may have alcohol related breath, he may have that sort of gait, he may be using as a comorbid, so it becomes very difficult. Okay, so withdrawal. So now we have completed one part of GHB toxicity treatment. So fine, the GHB mild toxicity, mild overdose or severe overdose we have managed. But if the patient is using GHB, they have very short half-life, and the withdrawals, they are very severe, and the patient either due to non-availability of GHB is having withdrawals, or have decided on his own to quit GHB, he may have withdrawal. These could be two reasons. He's not getting GHB because it's not widely available in our part of the world, and he may have decided on his own, okay, it's a lot of people here do, it's my willpower, I don't need any help. Sometimes people who use substance, they become very dramatic. It's our own willpower, we have used it for ages, now it's just one day we'll quit it. So they don't even bother to seek any advice of their GP or their psychiatrist or a addiction professional. They can have withdrawals. Withdrawals are very severe because it's very short acting thing, they have been using it for long. So what to do? As we have been repeatedly discussing, they mimic alcohol, they have a mechanism of action related to alcohol. So as we give benzodiazepines in alcohol detoxification or withdrawals, similarly we'll be giving benzodiazepines, but we need to be very cautious. You are giving benzodiazepines to catch a withdrawal, and simultaneously he had got some GHB from another source and he's taking them together. So we need to be very much sure. I personally, because there are very limited guidelines on GHB withdrawal management, but I personally would be very much comfortable by managing these withdrawals in inpatient. I would be very reluctant to give the patient good dose of benzodiazepines in outpatient, and thinking all the time he may get GHB. Then again, supportive care, we have to look for seizures, we have to look for insomnia, anxiety, dizziness. And again, last point, if you take my opinion, that would be inpatient. But if you take, you have to take on board the patient, the family, then your resources. So we need to take in account a lot of factors while deciding that this withdrawal treatment, supportive and a lot of benzos, they would be inpatient or outpatient. So another form of treatment, which is the best form of treatment, to prevent. So the best way to prevent is don't use GHB. Always the best solution, but not very practical. We all know that these patients, they are sometimes using polysubstance, and they have this, long history of relapse, remission, relapse, remission. So abstinence, complete abstinence is not always, the possibility. So a lot of people, even I have seen professionals in Pakistan, even abroad, they become very black and white. They lose the patient. Okay, do this, or otherwise you'll not be engaged with the service. That doesn't work. You have to engage the patient. You have to have some gray areas. It can't be black and white, either using a lot of GHB daily or not using it at all. Harm reduction. Don't use it with other substances. Don't use it with alcohol. Don't use it with GBL. Don't use it with benzos. Reduce the dose, and we have to invest in proper prevention. As I told you, a lot of people, they would think, the mode of prevention is just to tell the patient, okay, don't use it. This is no prevention, because this is not proper prevention. So other forms of proper prevention I'll discuss in coming slides. So I'll discuss in next slide. So recovery, how to recover from this. A lot of people, when they come to me, the family members or the patient who use substance, they say, okay, would we be recovered completely? Would we become normal? So I usually tell them, what is complete recovery? Who you think in this world is completely recovered? Or what do you think, what is normal? There is a famous saying from a psychiatrist to a patient: I am not okay, you are not okay, and that's perfectly okay. So there's nothing as complete recovery or as becoming normal. We have to reduce the harm, we have to restore adequate quality of life of patients, and in my part of the world, family members, because the link among the family is very strong in this part of the world. So inpatient detoxification and rehabilitation depends a lot on the available facilities and the cost bearing of the family. They're very limited outpatient programs, because in my part of the world there are no community nurses, there are very limited social workers, so it's very difficult for the patient to remain followed up in the community. It's entirely on his own will and family members. So that's why even for opiates, methadone program has never been successful in our part of the world. Similarly, if I told you before as well, if I give benzos to the patient in outpatient and they never come back, and then they use benzos with a lot of other things, there's no check in the community. So outpatient programs may not be very successful. Then if the patient is motivated, he is willing to reduce harm or quit, then we can give individual therapies. Like I deal with a lot of patients with emotionally unstable personality, which is also called borderline personality, or chronic PTSD. I offer DBT. So that helps. If the substance use is due to emotional dysregulation, poor stress coping, poor distress tolerance, then DBT can help. Similarly, we can have group sessions as well. Now, this is my favorite topic I'll discuss here, because this is basically the primary prevention and the proper prevention I mentioned in the previous slide. So a lot of people would be using GHB or other substances because they would be having primary psychiatric illnesses which are not managed adequately by their psychiatric teams, or they may have found it's difficult to go to a psychiatrist and get treated. There may be long appointment queues, and it would be very fine to get some substance from the street and treat yourself, at least for some time. So it's very important to look for psychiatric illnesses, for personality disorders, for depression, for anxiety. A lot of people we know, they use alcohol to reduce their anxiety. Similarly, they may be using GHB. They would be very anxious throughout the week, and on Sundays they would be going to a rave and they would be using these substances. They would feel less anxious, they would feel good. Then escape from a lot of social problems. We know the inflation rate in all parts of the world post-COVID. Other than inflation, there are a lot of things in COVID. People were locked into their houses. They had more chance to know their family members, and that raised a lot of problems. So these social problems, these economic problems, these job related issues, these relationship problems, people need escape. So whole week a person is stuck with his wife, with his children, with his very furious boss, and just one day he is having for himself and he is going to a party and doing GHB, doing alcohol. Now again, as a therapist, because I work as a psychotherapist along with with my psychiatric role, so we need to just shift those maladaptive coping and that poor distress tolerance to some healthy things. Then personality traits, this is most important. If you have cluster B traits, if you have this thrill seeking, this adventure seeking, you need to know, you need to do something new every now and then, and your society, as in developing countries, does not offer. In my part of the world, it's very rare to engage into boxing, into wrestling, into mountaineering, into judo, into music, into dance. It's very difficult due to number of reasons. So when it is difficult to engage into mountaineering, into some sports, into some music, and you have these traits of finding something new and adventurous every day, then you land into this business, this rave culture, these parties, this new and apparently nice drugs every week. So those personality traits needs to be channelized. That those personality traits can do wonders if they are channelized, and if they are not channelized, the person may land up in ED with GHB, severe toxicity. Then peer pressure. Okay, I'm going to party. Why not you? You're a coward man. You are mama's boy. You don't go to parties. Come on. So this peer pressure. So again, if you have some good things, your peers could take you to mountaineering. Okay, you are mama's boy. You don't go to climbing. You don't go to hiking. But if you don't have these, your peers would take into this. Then other drugs, smoking, cannabis, they are gateways. You'll start with cigarette smoking, then you'll go to cannabis, and that will open the gate. So if we need to stop these major drug uses, the dangerous ones, we need to even work for the prevention of so-called minor drugs, which are now almost legalized. The nicotine, the cannabis. So I tried to get some evidence other than my own experience. The own experience of a clinician lies on the bottom of the hierarchy of evidence-based medicine. So unfortunately, this bottom of the hierarchy is to be shared with you, because for GHB and other party drugs, the local data, the data of developing countries is very rare. I found some articles from India which were onto the epidemiological data of what substances has been used in parties, and GHB was one of them. Then I told you my own experience. This farmhouse party culture is increasing. And that group of population is, again, I told you, the personality traits. They want something new. They are fed up of alcohol. They are fed up of benzos. They are fed up of, even now ecstasy, even amphetamines. They want something new. The new is maybe, now LSD is very difficult to get. It's very expensive. And then it's smuggled in a very different sort of way. So it's not accessible to everybody. So this GHB is something new for them, and it could be transported easily as well. Now I have seen almost now 4 or 5 patients using this, and then that opened my eyes. And I tell you, I have worked in Ireland, I have worked in UK, I know some USA or Canada data as well. The emergency physicians, they are very less trained in managing this GHB overdose. And I have told you how difficult it is to even suspect GHB overdose. So, and I again tell you own experience as well, that these farmhouse parties, everybody is drunk or everybody is into drugs, and usually there are servants, household help, drivers, bypassers, which are taking these semi-comatose, these confused, these delirious patients to nearest healthcare facilities. So it's not just the training of ED doctors or psychiatrists or addiction professionals. This sort of awareness is needed even in layman, in a normal population who are not using these drugs, but they should be aware of this. So I think I have spoken a lot, and with a lot of speed. I'm sorry I speak too fast, but this was not very much interactive, and it was just a one-way flow. So that's why I was, I think, more fast. But if anybody has any questions, so you are more than welcome.
Dr. Usama, thank you very much indeed for that input. It was very, very interesting and raised some of the really important questions about not only what GHB is, but how can we identify its use? What do we do if people are using it? How can we deal with overdose? Have we got the expertise to actually handle the issue? And a range of things that we need to address in terms of cause, and therefore how we can respond to it and recognize it and deal with it. So many questions that I think you raised. I hope people will add to their questions to this. I wonder if we can begin and just ask that question about the use of raves and farmhouses, and is it something that we need to sort of consider, that when we now have the concept that a rave or a farmhouse party is therefore something bad and where drugs will be taken and people should avoid? Are we straight away giving an image that these things are bad things for young people who are looking, as you said, for pleasure and for something different? Their brain is developing into that area of wanting to exercise risk and so forth. How do you consider the need to consider the issue of the rave and the farmhouse parties? How can we educate people about that?
So that's a very good question. I, as a psychiatrist, I deal. I don't know how much idea you have about Pakistan, but I see a lot of youngsters. When I do DBT, so I see a lot of youngsters, and I always need to tell the parents that there is a new normal for this generation. This generation is a bit different, and you cannot call their new normal abnormal. So we have to go with their pace. But then there is, and I myself am fond of music and dance. There's no problem in that. And the rave culture or the party culture, when it goes beyond certain limits, so there's no harm in having music, having dance, having party, or having even controlled alcohol. There is no problem. As like I lived in Ireland for a couple of years, and even people meet there over pubs, so you can't stop them, and there's no need to stop them. But when this risk comes, so this becomes very important. That's why I more focus on primary prevention aspect, that these things should not be made, these things should not be available. But we all know that even in West, which are very controlled societies, you cannot buy benzodiazepines without prescription over the counter, but you can get them easily on the corner of the street. So this is a very complex situation. These youngsters with new normal who are more than 18 years, they have to take responsibility of their actions. This is very important. So you are going for a party, you can have music, you can have dance, you can have food, you can have alcohol. But when it comes to GHB, when it comes to some dangerous substances, when it becomes to some dangerous, risky behaviors, like one wheeling, a lot of these parties, people go there on their bikes by doing one wheeling. Now nobody would advocate one wheeling. Now they would have some unprotected or dangerous sexual activities which could never be advocated, and they may not be part of primary party scene. So this is very important. There's some personal boundaries. If the person is less than 18, definitely no party, it's not legal. If he is more than 18, he or she has to take some responsibility. I, as a psychiatrist or family, they can't take.
Yeah, thank you for that. It's very, again, interesting and challenging in society. Obviously, we all face that problem. We say what should happen and what would help to do it, but how can we provide those I don't know, precautions that will perhaps help with the matter? I've got one question here, very simple, and you've referred to it a little bit, but perhaps you could expand on it. What are the ways to prevent this problem?
Okay, so it starts from the womb of the mother. So if the child is born unplanned, so the course would start from there. So, but we can't go that far. It's personality traits. Personality start developing when you are conceived. So if there is childhood trauma, there is abuse, there is a very toxic household, and then bullied at school, and then there was harassment, and your personality is shaped in a way. I often tell people that after 18 years you return to the society, but society gives you for the first 18 years. So it really becomes parenting challenges, harsh parenting, or that's a complete other segment. But I have to touch that. You cannot fully blame. It's very difficult, as Jeff, when we were discussing these slides as well, and whenever I discuss addiction problem, there is a social model and there is a medical model. We as doctors, as psychiatrists, and addiction professionals, we give medical model. We say these are the patients and they need to be helped. But society has its own ways to give a social model, because otherwise there would be disruption in society. So drug trafficking is illegal. Selling GHB may be illegal, and that is very good. So again, one part of the prevention is that legal side of this should be very much strong. The government should take some responsibility that this should not be so much widely available. So this is one aspect. Good parenting and not letting your child become a personality disorder is an other side. And then, swallowing that raves would occur. Raves would be there in your society, parties would be there in your society. This is new normal, this is not abnormal. Once you swallow this, then you would be able to make some legislation about this. The problem in developing countries in my part of the world is people don't want to accept it. They say, oh, Pakistan is an Islamic country, there are no parties here. So I tell them, I'm a psychiatrist, I know that. So first we need to accept the problem, and then we would be able on individual and collective level to do something to prevent it. And again, the third part, if you have those traits, I told it's very much clear. This is basically motto of my practice. Give your youngsters alternate behaviors. Why would, if I'm using GHB, why would I leave GHB? Because I have nothing else to do over the weekend. I have so much aggression in myself. I want to box, I want to punch, I want to jump, but you don't provide me any opportunity. So only opportunity I have is to go to a rave. So this is very important. Boxing, wrestling, mountaineering, music. This is very, scuba diving, and even a lot of things. Even if there's inflation, I tell my patients, you don't get everything for a lot of money. A punching pad does not cause much of the money. Going to hiking on a mountain which is provided by nature doesn't cost much money. Having some good music, you just have to buy that piano once. But these things need to be inculcated in the society. But we are not doing it. We are just criticizing. As when I made those slides, I think I was doing same. We are just criticizing. These are bad people. These are doing parties. These are not from us. They should not be helped. First of all, we have to curb our attitude that we are normal people. We don't use drugs. So first, we have to be non-judgmental. We have to give them unconditional positive regard. We have to be empathetic, not the doctors, the whole society. I'm sorry, I'm talking too much.
For me, it's very refreshing to hear you expand and to see that what you mentioned about investing in proper prevention is something that we have to address, and it's not just about simple messages of just say no or trying to scare young people away from doing it, that it does need to address a whole range of factors in terms of parenting, in terms of what society provides, what opportunity is provided in the local community for young people to have an opportunity to do things that engages them. And they say it's more than just saying you shouldn't take drugs because they're dangerous. We have to look at what proper prevention really means, and I'm reassured in that message that you're giving. Another message here that says, could you just elaborate a little on your local experience of GHB use?
Yeah, so my local experience, as I've told already, is very limited, because there are a number of factors. GHB, if the patient is telling me himself, because I see a lot of youngsters who are from universities and who know what they are doing, and they make good bond with them because I'm non-judgmental. I give them unconditional positive regard, so they share with me, and they themselves, very nice of them, they told me that we are using GHB, and I was shocked. GHB in Pakistan? one person, second person, third person, fourth person. In 8 months, 4 or 5 patients. So I don't have any experience, personal experience, because I don't work in ED of the overdose. So in a rave or in a party, from where 4, 5, 6 people are coming to me and telling me they used GHB. A lot of people, other people who use GHB in the same party, they may have gone comatose. They may have been taken into EDs where nobody knew. So my experience is that this problem is there. There are raves, there are parties, there is GHB. So we need to train people on this. That is very important.
Okay, thank you. And linked to that, is there any specific therapy or replacement therapy available yet, as in use of methadone for heroin use?
Yeah. So as I told that for withdrawals, we give quite good dose of benzodiazepines, because the GHB, that is very short acting, and people use it 3 or 4 times a day who are not using it for parties, but they have become dependent on this. So there are two type of people. One who use them like 15 or 20 days on a party, every 15th or 20th day. The others who have become dependent on this. They are using it 4 to 5 times a day. It has such short half-life. So when they are managed for the withdrawals, they are managed with benzodiazepine. That is what up till now, the very few available guidelines they tell us. So that's why I'm very much reluctant to dispense high dose of benzos for outdoor withdrawal. So I would be more interested in inpatient withdrawal, management of withdrawal with benzos.
Okay, thank you very much. One question here, dear Dr. Usama, I want to know that when we face with the issue, which is the best way for the primary step that our clients have both addiction and mental health problems? So first, which one is the starting point? Is it the addiction or the mental health issue, which I think is what the questioner is asking?
Yeah, so actually, it's when you talk of West, in West, there are two entirely different pathways. Even when I was working there, we had these patients and we straight away used to refer them back to GPs that link them to addiction professionals. Don't send that to us if they don't have primary schizophrenia. Even if they were depressed or anxious, we said no, drugs, addiction, send to them. But in third world countries, in Pakistan, addiction is dealt by a psychiatrist mainly. So if you are working in my part of the world, you have to refer the patient to a psychiatrist. If you are working in West, there you have to link him with the local addiction team.
Okay, interesting. And just one question here. What segment of India's society is most affected by GHB use and the push vectors that lead to its use?
So I don't actually work in India. I work in Pakistan. They are two neighboring countries. Once we were together, but now we are neighbors. So, but the socio-economic and the other structure that is very similar to in India and Pakistan. So again, as I told, some people consider it that these parties, they are from the elite class, they are from the high socio-economic group. But the problem is in all the a lot of people, they don't, it doesn't cause much to go to a rave which is already happening and you have a friend there. So it can be in any area, it can be in any socioeconomic class. If you have a history that the patient is landing into your ED from a party, a bell should ring in your ears. It would not be merely alcohol, it would not be merely cocaine, it could be GHB, it could be GLB, it could be GHB analogs, like other analogs.
Okay, thank you. There are many other questions that I don't think we can get round to in the time that we've got. So I would just like to end by thanking you so much for the input you've given to us, and for your offer for people to contact you if they've got further questions or issues or would like to know more about the work that you do in this area. For me, it's really been a learning experience. I need now to go and find out more, and I think that's always the challenge of a webinar, is to say, well, I'd like to know more about that. Can I find out more? I'm obviously particularly interested in how you've spoken about the need for proper prevention, and the issue of personality traits, and whether that and how that might lead to a problem of GHB use. Perhaps I can ask you one final question before you go, and that is, how can we avoid stigmatizing people that do get involved in drug use generally, but in GHB use specifically? Because it's very easy to both end up by saying all raves are nasty and all people that go to raves end up using drugs and GHB, and they become actually stigmatized because they're seen as bad people and drug users. How can we avoid that?
So I think that this is a question I really want to answer. Again, another aspect of my psychiatry practice is to inculcate in traumatized people about post-traumatic growth. So if the person is indulged in any substance use or GHB, or even he was found comatose at a rave and he was brought half dead into an ED and then he got a new life. So this trauma may change his life if he is dealt without stigma by the society. And how society could end the stigma if the society itself believe on post-traumatic growth, that traumatized people, the patients who are suffering from any psychiatric illness or GHB overuse, they could turn into entirely different people. So what society has to do? Society has to do three things, which I have mentioned already. Non-judgmental approach. We need to be non-judgmental in our words, in our expressions, in our body language, in our whole life, not only for others, for ourselves as well. Then unconditional positive regard. You cannot say a patient, okay, once you leave GHB, only then I'll be able to offer you help. He would never come again. And third is empathy. You could be at his place. He may have some bullying throughout his school, which made him anxious and led him to GHB use. So don't see behavior. Don't give behavior on behavior. When we stigmatize, when we just give our behavior on one behavior. So there's a behavior GHB use and we'll give a behavior of making it stigmatized. Just relax yourself, have some breaks and see what could be cause behind this behavior. What could have led this gentleman who could be at my place and now he's using this GHB. So empathy, unconditional positive regard, non-judgmental approach, and last thing, I am not against parties, I am only against GHB. Thank you.
Thank you very much. A very reassuring, positive answer. Thank you once again for giving your time and your expertise to us. Usama, thank you for organizing it. I'll hand over to you for final words. Thanks very much indeed.
Thank you very much, Mr. Jeff. And first of all, I would like to thank Dr. Usama, our young and passionate psychiatrist from Pakistan, for sharing your wonderful presentation and wonderful knowledge with us and our audience as well. And thank you, Mr. Jeff, for all your scientific support and support to conduct this webinar as well. On behalf of ISSUP Pakistan chapter, I would also like to thank all our audience to join us and sharing your valued information, feedback with us. I hope we will conduct another webinar with different topics, but I would also like to thank once again Dr. Usama for your precious time to join us, and I would also like to thank ISSUP global team, all ISSUP executives and leading team for providing us this wonderful platform to sharing the knowledge about different topic. And particularly I would like to share Miss Livia, Miss Olam, Miss Olivia, Mr. James and Mr. Jeff for always having your kind and positive support to us to take new initiatives and provide positive and new information with our audience. Thank you once again. And I would also like to share with our audience that a recording of this webinar will also be available on ISSUP website and YouTube channel. If you may miss any part of this webinar, you can go there to visit ISSUP website and YouTube channel and watch again. And you can also share this information in your professional working group and your friends as well, so they can also learn about this topic, GHB. Thank you once again, ISSUP team and Dr. Usama, Mr. Jeff, everyone. Thank you for joining us.